Hello everybody, nice to see so many people joining. If I could just ask everyone to put their microphones on mute, please, while we're doing the presentation, that would be great. Thank you. So I think we'll make a start. But hello everybody, and welcome to the Primary Care Strategy listening event that we are really pleased to be hosting on behalf of Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board, here on known as Bob ICB, but for brevity's sake. And we have some representatives from Bob ICB who will be taking us through the draft strategy. So the webinar today will be an hour long. We will do introductions shortly. There will be a presentation that will last approximately 15 to 20 minutes, leaving plenty of time for questions and feedback. And we will, after the webinar, we'll make sure to post the recording on our website, as well as the engagement portal of the Bob Integrated Care Board as well. So any questions that we don't get around to answering in this session, we will follow up, and there will be answers on the engagement portal. So my name is Zoe. I'm Chief Exec of the Healthwatch Bucks. I know many of you, I think we've met before. I'm just going to go round and introduce members of the Integrated Care Board. So can we start with you, Anna?
Hi everyone. My name is Anna Marcus. I'm head of primary care integration for the ICB. I met some of you for the first time back in November, so good to see you again, and hi to everyone who's new.
Thank you. Philippa?
Hi everyone, I'm Philippa Baker. I'm the place director for Buckinghamshire within Bob ICB, which basically means my role covers coordination across health and care in the Buckinghamshire part of our patch. It's good to see you all today.
Thank you. And Louise?
Good afternoon everyone, I'm Louise Smith. I'm your Deputy Director for Primary Care across Bob.
Thank you. Can we go on to the next slide, please, Belinda? Thank you. So just a bit of housekeeping before we get onto the body of the presentation. So we're going through the draft primary care strategy today. It is aimed at PPG leads, and most of you are involved in your local PPG. I think most of you have got your microphones muted, but if you could make sure that they're off whilst we're doing the presentation. And when we get to the Q&A session, you can put your questions either in the chat bar at the side, or if you raise your virtual hand, we'll take the questions in order. And then, as I mentioned previously, we will post a recording. The session is being recorded. And we will post a recording on both our website and the engagement portal on the ICB, and we will put that link in the chat shortly. Okay, thank you. I think over to you, Anna.
Great, thank you. If we go to the next slide, so I think just to do a bit of scene setting first before we get into the strategy. We wanted to put together a strategy as an ICB because we recognize that there are a lot of pressures right now on primary care with things such as high demand for GP appointments, in particular in dental appointments, and access in general to primary care, inequalities that a lot of patients are experiencing, and issues with meeting that demand with the pressures on our workforce, high workload. So we wanted to be able to put together a strategy that addresses those challenges, as well as the direction of travel as at a more national level too, which is to better integrate primary care. So when we talk about primary care in this strategy, what we're going to be discussing is general practice and pharmacy, optometry or eye health, and dentistry. So this first slide is really kind of taking stock of what things look like with primary care in Bob, so Buckinghamshire, Oxfordshire, and Berkshire West, which is the patch that we cover. So you can see a bit about how many GP practices we have, how many primary care networks, pharmacies, dental practices, and then all serving a population of 2 million people in Bob. So the strategy, which we'll get into and share with you the draft that we've got so far, is trying to address the challenges that we're facing in primary care and what it would mean to have better integration of services, how we're going to work together as a system to deliver this vision. So if we go on to the next slide, we wanted to first start by laying out some of the many strengths that we've got right now in Bob. So we know that there's significant demand and issues with access to general practice and dentistry at the moment, but that's happening all across the country. Bob is actually doing better than other parts of the country with access, though we still know that there are issues we need to address there. In Bob, we've had pretty high uptake actually of our community pharmacy referrals, which, if you're unfamiliar, that's for certain minor illnesses, you're actually able to be directed to a pharmacist to address minor illnesses. So it doesn't necessarily have to be a GP. That's a newer service that has been doing very well in Bob. We have a lot of different groups that are focusing on more prevention and inequalities within Bob. So in Bucks, for example, in Buckinghamshire, we've got Opportunity Bucks, which is a partnership with the local council that is focusing on the 10 most deprived wards in Buckinghamshire. So these are some of the things that we're doing around inequalities. We've also started developing as a system a population health management infrastructure. So we've got something called Connected Care, which is a software platform that helps providers to be able to do things like better triage people to the places that they need to be because they've got better information on what's happened to people outside of kind of their practice. So that your GP would be able to see things like if you've been to the hospital recently to help with making better decisions on triage. We've also got some schemes for how we're commissioning dentistry that have really helped some of the practitioners within Bob to better deliver care to more deprived areas of the place. And then we've also got at-scale delivery structures that have been working very well in Bob. So what this has meant in some places is that we've got things like a GP federation, for example, which can help with providing where practices may not be able to provide all the services themselves. We've got within Buckinghamshire, we've got a federation that's able to help practices with meeting demand with other types of services that they can help with. So those are some things that we're doing very well across Bob, but also in Buckinghamshire. If we go on to the next slide, though, we recognize that there are also obviously a lot of challenges that we're trying to address with the strategy and that really require new ways of working. So one, which I think everyone will be very familiar with, is the worsening experience of accessing primary care. We know that it's very challenging to book an appointment with GP surgeries as well as dentistry in particular, and that experience for patients has decreased over the past few years. And this has a lot to do with also not just the demand on practices, which we'll get to in a bit, but primary care staff in particular are really feeling under extreme pressure. They've got a higher workload, they've got more demands from patients because of the complex care that they're trying to manage. We're seeing that 1 in 4 adults in Bob are living with 2 long-term conditions, 2 or more, which means that people obviously have a lot of needs. They need to be able to get that care. So more care is needed for the population, but we're having difficulty with keeping up with that demand. So, and that's for a number of reasons, that it's difficult to increase our capacity to be able to care for patients in that way. So there are obviously some funding constraints that we're under at the NHS. There are issues with recruiting and retaining staff to the workforce. And we're also facing estates challenges. So essentially what we have is more demand, more complex care that's needed at a time when we're having difficulty with the workforce and retaining the workforce, and funding, and a whole range of issues, which is what we're trying to address with the strategy. So if we go on to the next slide, that's kind of setting the scene for kind of acknowledging where we're at in Bob, and then saying kind of what do we want to do as a system then to meet these challenges and really work to develop new ways of working across Bob over the next few years. So as a system, some of you might have seen we've had a joint forward plan, which also kind of reinforces this vision that we're putting forward in the primary care strategy, which is really that everyone in Bob has the support they need from primary care and working in a more coordinated and integrated way that helps support people to stay well and in the community. So we've got three main ways that we are going to be doing that as a system. One is through access and ensuring that people get to the right support the first time to meet their needs. We'll go into all of these in more detail. One is on providing more personalized, proactive care for people with complex needs through integrated neighborhood teams. And then the last is on more targeted support, providing more preventative services to keep people well for longer. So if we go on to the next slide, so this is getting into a bit more on access and ensuring people get to the right support the first time. So I think part of what we're doing here is saying that there obviously needs to be a front door for how people get into access services, but getting access to services may not be with your GP. It is going to be with your GP if that's what's needed, but there are other parts of the system that may make more sense for you to be triaged to, depending on what the need is. So pharmacists, we've talked about that already, might be able to take on minor illnesses if that's what you're facing. There might be social prescribers that can help with getting you to kind of a voluntary service that we've gotten in the community. So it's really making sure that that triage is helping you to get to the right place at the right time with that initial contact that you've got with the system. We recognize that when you're not able to get the care you need right away, that some people feel they need to go to A&E, which could be right if you're not able to get a GP appointment. So it's trying to help make sure that that doesn't need to happen and that you can get to the right care at the right time. Go on to the next slide, which is providing more personalized and proactive care for people with complex needs supported by an integrated neighborhood team. So a lot of what the neighborhood team concept is trying to do is first just recognize that people that have more complex needs but also want to be able to stay in the community may have issues that are affecting your health that aren't purely medical. A lot of it might be medical, but some of it may not be. And in those cases, it's going to be important for our providers in the system to be able to collaborate with other providers in the community to get people the right care that they need. So this could mean, for example, if people are having issues with housing or need some sort of benefits, that a GP surgery might be collaborating with those agencies in the community to help people get more joined up and better care. And have a more wraparound support from kind of more of this multidisciplinary team that has a much broader range of specialties and skills that they can draw on to make sure that people are getting the right type of care depending on what's happening with them. So essentially what this is going to mean is having a really defined population and developing a service around that population to help them with staying well in the community, staying out of the hospital if possible. This could mean especially that groups in more deprived areas could have better wraparound care so they're not having to use the emergency care system as much as before. But ultimately, we need this model of being able to support our providers to be able to work together and provide a structure to do that so that they can provide this kind of more wraparound care for patients who have more complex needs. I think that's all I'll say on that one for now. I think one other thing just to emphasize with the integrated neighborhood team is that one of the ideas too is that by kind of getting support from these other disciplines and more input from other disciplines to really spread out this work and to help get patients to where they need to go, that this is hopefully in the long run going to allow more time too for GPs to be able to focus, for example, on patients when they're coming into the surgery and provide more of that chronic disease management proactive care if they've got more time, because patients with complex needs are getting more of the support that they need. But let's go on to the next slide. So we talked through the first two pillars. The third pillar is designing more targeted support for everyone to stay well by understanding the population. So essentially, we want to be able to provide more preventative care to the population in Bob, and really be able to be more targeted in how we approach patients and being able to provide that preventative care through population health management approaches. So being able to identify, for example, people who may not have had a health check in a while, and being able to call them proactively to bring them in for a health check if it's been a long time since they've had that. You can see kind of we've got a few of the stats with the challenge that we've got today, that we're seeing a real disparity in outcomes across Bob, with 60,000 people, for example, living in deprived areas that develop poor health than those in less deprived areas. And so this is really a way that we want to be able to say we need to equalize some of those outcomes by being more targeted in our approaches. And so using kind of the population health management infrastructure that I referred to earlier to help with finding those residents that we can try and get them in to see their primary care providers. So again, this is really trying to put primary care at the center of the prevention activities to promote healthy lifestyles. It's going to mean, again, partnership with other providers in the community. So working with public health colleagues and local authorities, for instance, to be able to connect people to with different programs that are going to help with leading healthy lifestyles. And also being able to do things like be opportunistic when you see a patient in a different setting, to be able to do things like blood pressure checks while you've got somebody in for another service. So these are the types of activities that we'd be planning to do to provide better preventative care. I'll go on to the next slide. Part of this too, so we've talked a bit about what the vision would be, the model of care that we're pursuing. These are just acknowledging the 4 enablers that are going to be essential for us to be able to deliver on this vision, and what we're going to be doing as a system to support all of our primary care providers to be able to deliver on this care. So supporting our workforce. We talked a little bit about digital and data and infrastructure and tools that we want to be able to give to our staff so that they can better coordinate care amongst our partners. We know that we've got a real challenge with estates and either needing to expand estates or upgrade the current estates that we have. That is going to be a challenge for a while, and that's part of what we recognize we need to develop as part of the strategy, and thinking too just not about kind of the longer term needs with the estates, but how we can get really creative in the shorter term by being able to do things like sharing estates and co-locating teams in one spot, so that we can really take most advantage of the current estates that we've got today. And the last bit obviously is resource. So funding is an issue. It's really going to be looking at the finances and the budget that we've got today and how we can work differently with the resources that we have. So I'll go on, if we can go on to the next slide. This is again kind of another summary of our priorities for delivery. So you can see kind of the 3 pillars of the strategy that we've just talked through. So for the same day care, access to the clinic, making sure that people can get to the right place at the right time. Ultimately, what we want to be able to see is an improved patient experience and making sure that people get the urgent support that they need so that we can have a bit more capacity in general practice, in pharmacy and dental to focus on those with more complex needs. The integrated neighborhood teams, again, is the framework of allowing kind of all our community providers to be able to work more closely together to provide that proactive, personalized care to patients with more complex needs, so that ultimately people are better able to manage their conditions, and so they don't need to go to the hospital as often, ideally, is one of the goals. And ultimately, the system is working in a more coordinated way. And the last one is on prevention. So again, thinking about better ways to target our support to keep people healthier longer and in the community. Our proposal for the strategy is that we focus for the first year on CVD, or cardiovascular disease prevention. This is something we believe that this is a good area to focus on because kind of every part of the system works with people with CVD at some point. And so it's a good way to bring people together to really focus on an area that has a very large impact on Bob. It's one of the highest reasons for illness and death in Bob. And we think that this would be a strong focus area for us since it impacts so many people across the patch. So we'll go on to, I think, the last slide, just giving the overview of the presentation. So there are going to be other things that we're going to continue to focus on within Bob, which are kind of outlined in each of these columns in general practice. For instance, we're going to continue to refine the ways that we're using the NHS app so that people have are better connected and getting their own data. For pharmacy, for instance, we talked a little bit about the community pharmacy referral service. So this is rolling out another initiative that's pharmacy first, that's starting in 2024. We have a lot of different areas that we're going to be focusing on throughout the year, which we wanted to lay out here and show you what some of those other priorities are. But as a system, the three that we just went through are kind of going to be a really big focus area for the primary care strategy. So I think I'll pause there because I want to make sure we've got time for questions and answers. So Zoe, I'll hand it back to you.
Thank you. Is there a final slide? Sorry, there was a slide. The next slide, is that? Yeah. Okay.
Oh,
so I think I think we will go over to questions now. But it is just to say that I think the consultation is running until the 29th of February. Is that right? So people can feedback in this session on the through the portal, and you're doing a number of focus groups, I believe, aren't you, across Bob? And then, so when is the final version of the strategy due to be published? Because presumably you're going to go away and look at the feedback, and what's the date?
Come in? So the final version of the strategy won't be published till it's approved by the ICB board in July. So it will be a couple of months after that February deadline, and that's in order to make sure that we've got all the information in and that we've recognised that feedback and built it into any further iterations.
Great. So should we go over to questions now? Is there a question in the chat? Does anyone want to put their hand up? Okay, I've got some hands. I can see them now. Okay, let's start with Heather. You need to unmute yourself, Heather.
Sorry. Good afternoon to you all, and thank you for that presentation. It sounds wonderful. I just wonder, with so many people coming to hospitals and GPs and the shortage of money, which are the priorities then you could focus on so the general public can see some movement going on rather than a little bit over a wide area so they feel frustrated and can't see anything.
Do you want me to come in? So in one of the other slide decks, we actually have a proposed timeline, and it probably is in the extended version of the primary care strategy, which will be on our website. And we could probably show you, find you the number of the slide that it is. But basically, the bit that we're going to focus on first is the same day non-complex access. By doing that, the ambition is that we free up sufficient time from general practice to then consider other elements of the programme. So although this outlines our strategic approach, so the vision that we're aiming to, underneath this work will sit an action plan, and the devil will be in the detail, as always. So we want to be quite clear and open with the patients and public around what those actions are and over what time scale.
Thank you. Is there a chance that all the computers are going to be talking to one another? Because this seems to be one of the problems. If you go to an Oxford hospital, they can't talk to Stoke Mandeville or Wickham, or vice versa. You have to go back through the GP, and then the GP may be able to access a specialist or something like that with the reports.
Yes, and that is the ambition. We've got our summary care record that we are working collectively to look at, so that we can read and write into each other's notes. And there was another point I was going to make, actually. One of the other elements we're trying to do is this reducing bureaucracy for general practice, and therefore to refer one place and then need to refer to another place and then do various letters, when actually just a simple electronic communication would suffice. You know, that's the sort of thing we want to promote and do a bit more of.
That sounds very good. Thank you very much.
Thank you, Heather. And I think the link to the strategy that is in the chat bar now as well. So there are the different versions if you click on that link. Okay, let's go to Barry. Hi, Barry.
Yes. Hello, everybody. I have a problem with this document. It's analysed the problems. It's set out a lot of aspirations. It's very thin on solutions. There's nothing in there that really sets out to change and reorganise. And as that, I see it being just yet another NHS document, which in 24 months' time will be rewritten. When are we going to get down to actually solving some of the problems? We're not even analysing the problems particularly well in a practical way in this document. It doesn't recognise the detailed problems. Take IT, for example. We've allowed GP practices to introduce their own ways of dealing with appointments, which has actually taken the whole system backwards. We had a very good appointment system set up within various systems. I know there's several different systems, but the basic appointment system was common with NHS App, it was with Patient Access, or any of the other companies that were providing that. GPs then, when asked to give a service to patients which responded 100%, installed their own systems, which were in fact a backward step. In fact, most of the systems that have now been introduced, like Accurix, are basically just paperwork systems. They're form-filling systems. They're not proper IT systems. They're systems that just go back to the old days where you have to go and fill a form in to get anything done. A typical example of that is they're only operative during working hours practices, which is crazy. With an IT system, the major advantage is it works 7 days a week. These systems limit patients to only being able to apply to practices within working hours. That's a tremendous backward step, and there's no mention of these actual practical details which are holding things back. I just see and taking at least 2 years to develop any sort of practical operation that is going to improve things, because this document is just at the very early stages of saying what we need. It's not getting anywhere near answering the questions of how we solve it. That's my opinion on it anyway. Perhaps somebody would like to comment on what they feel about that.
Thanks, Barry. Who would like to pick up? Louise, let's go to you. Thank you. And then Anna.
I don't mind if one of my other colleagues wants to come in. Because I've been immersed in this for a long time. Would you like me to go first, or shall I hand over to Philippa or Anna?
Hand over to Anna, I think, and then Philippa, and then you can come in, Louise.
Yeah, I think this will probably be a joint answer to this question. Just really good. And so I guess a couple things. One is that some of the solutions that we have proposed, such as more integrated working through neighborhood teams, it's a newer concept. And I think part of what we're trying to do is not be overly prescriptive with how that should look, just because I think it is going to require some experimenting in each of the different neighborhoods to find a good solution that works. One of the things that we're going to be doing as a system is, Louise mentioned kind of the plan that we have for how we will mobilize this and implement this across all 3 places. And part of what we want to be able to do with that is see what's working in each of the different places to be able to spread that. So if we see something is working really well in Buckinghamshire, to be able to spread that to Oxfordshire, Berkshire West, and vice versa. I think it's a fair point on the digital components too. I think one thing that we have to be really mindful of is that with a digital solution, that's going to be one way to get an appointment that isn't going to work for everybody. And so we need to make sure that we have ways to be really inclusive with how people can get access to GP appointments, dental appointments, whatever it is, because it's not going to be able to cover everything. But I know that that might not be all what you wanted to hear on digital, so maybe Louise or Philippa has something that they want to add there. So I'll turn it over to you guys.
Should we go to Philippa, and then we'll take another question if that's okay from Paul.
Thanks, Barry. I just wanted to sort of recognise a lot of the points that you made and the complexity of what we're dealing with here. And, you know, we're all patients as well. So, you know, recognise some of those frustrations. I wanted to make a more general point, which is about how general practice in particular is organised and what we can and can't control at a local level. So there are elements of how the system works that we just can't control at a BOB level or in a Buckinghamshire patch. So, for example, the national GMS contract and what's included on that, that's negotiated nationally. GPs are also independent businesses, so they get to choose what type of IT they have, etc. So there are certain elements that we can't really mandate, and so there are some limitations to what we can do locally. But what we've tried to do in this strategy is look at the things that we can influence locally, like how we work together, using integrated neighbourhood teams, what kind of triage systems we create so people can get access to their GP, etc. But yes, recognising that there are some constraints within which we are working, and we can't address all of those because we don't control all of those locally. Louise and Anna are the experts in primary care and can correct me if I'm wrong on that, but I just think it's an important nuance really, because GPs are independent businesses.
Thank you.
Can I just respond on that? what you're really saying is that as long as we have the current structure of private practice, there's a limited amount that can be done to reorganize things. That's what you're saying. That really points to me to the fact that we have to do something about the structure of general practice, because it just isn't going to work until that's sorted out. It's past its sell-dying date. It's a structure that was designed for another age. It doesn't work anymore. And so we're all in a state until we bite the bullet and do something about that.
Thank you, Barry. Do you want to come in there, Louise?
Yeah, I was going to say we do have some practice managers, I think, on the call, but you know, we're not going to change the model of primary care and that partnership model, and nor is it our intention to do so, because sometimes that can work really quite well. I think what we need to do is give primary care the tools they need to change, and we need to support them to do so as a system. So this is the first time that we have got the whole system and our patients and public understanding primary care en masse. If everybody knows the problem and can help with the solutions, we're more likely to achieve something positive. So, you know, I feel this is a really positive document. It's the first of many. Do I think this is going to take a few years? Well, yes, it will do. But it is a really positive start. And like I said, the action plan is kind of where it's all going to happen. I'll also in the chat just say another couple of documents you might like to read to accompany this one, in case you're bored at night.
Thank you. I think we'll go to Paul and then we'll take the question in the chat. That's okay, Paul?
Hi. Does the ICB have a vision for the role it would like patient groups to fulfill within the new primary care strategy? Tough one.
So nothing that we've defined at the moment, but we do have an event on the 20th of March to which patient groups are invited, and one of those topic areas will be co-production. So it's actually how do we work with our patients and public on those services.
And does that event, who's invited to the event? Is it GP practices as well?
Yes, it is. So it's system partners, GP practices, LMC, our pod colleagues, pharmacy, optometry and dental. So it's quite a big event. And Zoe, I think you're coming, aren't you? And I can't remember how we've allocated.
The Healthwatch Bucks is going. I think each Healthwatch is in Bob has got an area. I know Mike is coming. Mike's on the call. I don't know if any of the other PPG leads have had an invite or how you want to manage that.
Up to now, no, and this is the first we've heard of it.
Okay.
I've just put something in the chat so that you can register your interest in that event, and anyone who gives us your email, we can send you a link to join that.
Thank you very much.
Thank you. Okay, Mike, your question in the chat. I think have you had a response to that? Do you want to come in at this point?
Well, I've gone back on the answer that Anna has given me. If you want us to write out to our members and say this in a snapshot is what the world will look like in 12, 18, 24, 36 months time, I don't have that piece to hand.
Yeah. Yep, we do have actually, I think, a bit more of what you're trying to get at. I'm trying to find the page in the full strategy document that tells from the patient perspective what this will feel like. For example,
I've seen that.
Yeah.
that's a little bit the exact dementia example, for example, is a little idealized, and the other examples where you've got sort of flow charts get a bit complicated. I mean, you have to think that the majority of people have never heard of Bob and have never heard of a primary care network, and are now being told about integrated neighbourhood teams rather than primary care networks, which is, you know.
Yeah, I mean, yeah.
Health boards.
Well, and maybe that's actually something we could follow up with folks on this call on, is developing, I think, better case studies that will resonate more with people on what this might look like in this new world.
But
can I just interrupt you there? Sorry, Annie, can I just interrupt you? It's not just developing things, it's how you get them out to the public. There seems a massive miss that you create all these documents, and from the vast majority of the public, they have absolutely no idea what's going on. So you really do need to think about, in a proactive way, it's not just putting things in surgeries, because lots of people don't go to surgeries, and when they go to surgeries, they go to surgeries with a specific need, not to gather information. So you do need to think about that. Lovely slides, but until you get it out for people to consume in a consumable way, you're wasting your time.
So Mark, I think this is actually getting at something that's a longer term project that we started to discuss at the PPG meeting back in November, which I think you're right. I think the folks at the last meeting were really saying that they'd love to be able to be helpful with, you know, we've got new types of staff that are at GP practices, for instance, with the additional roles. And I think people are unfamiliar with what those roles are. And we'd really love to work with you all to develop kind of how can we talk about those roles with our patient population in a way that's going to, I think, bring that out more than what we've got today. And it's not just a flyer, it's going to be creative ways to communicate with the larger population. That, I think, what you're getting at is a much longer term goal. And that's, I think, really one of the things that we want to work on with this group together over the course of the year, of how we can better communicate. But so I think in the short term, we've got.
I think, Anna, you need to start at the beginning, if not before the beginning, if you're wanting to get buy-in from your population, who are the ones who are actually going to use these services, and if you want to get them accepting the change and the benefits and actually using the new systems, they need to be in at the ground floor, and getting them in at the ground floor for your benefit as well as ours. You need to actually explain in bite-size globs that we as PPGs, among other things, could put out to our members, and we're a useful conduit to actually explain what's going on and the different stages, and if it changes again by July, and if it changes again, and how you're going to form integrated neighbourhood teams, and why they're going to be different from the area of a primary care network, and all these sorts of things. You have to take us with them, with you, not tell us.
Definitely. Some of that is going to be co-design of these services too, which is something we should discuss when we're starting to develop the neighborhood teams. So yeah, definitely take your points.
Thank you.
So who within the organisation is responsible for communication? Who's responsible for communication?
So Mark, I think it's all of us are responsible for communication. We do have a director responsible for comms, and part of our team is with us today. But we recognise there's a lot to do, particularly on the communication strategy side related to the primary care bit.
Can I just do a plug for our survey, which all PPG leads should have had now, which does, I think, ask Fiona about communication with the ICB, and how PPG members would like, you know, what they would like to see really in terms of that communication. So do let us know if you haven't had that through. I think, Dennis, can I go to you, because I've seen you've got your hands gone up and you put something in the chat. Can we go to you next? need to unmute yourself. You need to unmute.
Muted.
And again.
Hello.
That's it. Thank you.
Okay, sorry. I was disappointed to see you list GP access and quality metrics as a particular strength, just because it's in line or above the national average. I think most people will see that being equal to what they recognise as a failing cannot be listed as a strength. I mean, what I'm saying is primary care and access to GP appointments, it may be better here, but to list it as a strength, I just don't see that, because it's still a real challenge to people in the Bob area to get a primary care appointment.
Please, could I come in on the quality aspect, Zoe?
Yeah,
only because we are very, very fortunate in this area. The quality of our services is second to none. In Bucks, you're all outstanding or good, CQC rated. And in the other two areas, there's literally only 2 other surgeries. So I do think I think once you get in the door, and I don't disagree from your point, you are cared for well.
Once you get in the door, and I spend a lot of time chatting to our patients, it's getting in the door. And once you're through the door, and we'll all agree, once you're through the door, the hospital or wherever it is, then it's good. It's just getting through that door, getting through the 8 o'clock rush, getting to actually see a GP.
Yeah, we hear a lot about that as well, Dennis. Thank you.
Secondary point I had there is, quite frankly, with 8 million on the almost 8 million waiting for secondary care, I mean, the GPs are having to look after all those 8 million people, keep them fit and alive before they get to secondary care, which is just putting such a huge strain on the system. So really, until the backlog is cleared, primary care is going to be really struggling.
You. Does anyone want to come in on that?
No, just to highlight, there is a separate piece of work on that. I don't know if you're familiar with it, but if not, it might be worth. Zoe, I wonder if maybe it's worth another session on what's being done with secondary care to
do that.
Yeah, reduce those weights and support there. There's a whole different recovery plan associated with the planned care piece.
We can do a separate.
May I ask a question
on that? So
do I need to wait?
If you put your hand in the chat, I'm going through them in order. Okay, so I've got Frank now. Thank you.
Yeah, thanks, Zoe. Hi, Frank Donlan. I'm chair of 3W Health PPG up in rural North Buck. I want to go back to the earlier exchange between Barry and Philippa, because when Barry says there's nothing really going to change, well, actually there is. There's a very profound change. Priority 1, I think priority 2 and 3, he might well have a point there, but priority 1 is, I mean, that is a proposal for a major change. Have people realised that if that comes to pass, all primary care or general practice access will be via the neighbourhood hubs and not directly via your own practice? Although you'll start the journey there, but the triaging will all be done in a neighbourhood hub, and the action will be collated there. And it also will overcome Barry's point about we've got many different systems operating now in terms of managing access. So my question is, how do we think the GPs themselves are going to respond to this proposal? Because I think there could well be quite a difference of opinion. And how are we going to persuade them if we want to do it?
Yes, I just want to say, Frank, I wasn't saying that nothing's going to happen. What I'm saying is there's a lack of ideas as to how the aspirations will be met. So my criticism is not so much that the document hasn't analysed what needs to be done. I think it's done that pretty well. But when we get down to the real nub of how do you do it, it's a bit thin. That's well, my problem.
Neighbourhood-based triage hubs are quite different to what we have now. So how are we going to persuade GPs if we think it's a good idea?
Louise, do you want to respond to that? Persuading GPs.
Yeah, I don't think we're in the business of persuading GPs. I think we work with them to come up with a vision of something that they think there is value in, and when it comes to that mobilisation plan, we work with them to outline how it could be delivered. Now, none of this needs to be done in the same way or the same. We take a basic principle and approach, but actually it could be different depending on what unit you're working with, whether that's a practice, a PCN or a federation. And actually different people will want to do it slightly differently, and that's why we use something called service improvement methodology, so that we can take people that are really interested and want to adopt something early and have their own views of how that they do that, and they will start off on that journey, show us the learning, show us the results, share them with colleagues, and we start to get a little bit of change. And then others might think, you know what, that might work for us, but actually we want to do it in this way. And that's essentially what Anna's team will be supporting general practice to do.
But we need some pioneers.
We do, and we do have some. We have some excellent work going on, and I think that case for change that I've mentioned in there, we do have some of our local examples in there as well.
Yeah. Thanks, Louise.
Thank you. Brian, can I just check on you, because you did have your hand up. Was there a question that you had? Ooh.
Yes, can you hear me?
Yes.
Yeah. Yes, some of what I was going to raise earlier has already been covered, because I thought, yes, it's a very good idea to produce a strategy, and Anna has done an excellent job of outlining what that is. But when Philippa came in and started to talk about, but of course the GPs can, well, basically do as they wish, I started to think about, it's all very well producing a strategy, but where is any accountability? So I don't know what metrics you're going to use to measure the success of the strategy, but if at the end of a period you determine that a lot of people have decided not to go ahead and get involved with this, then the strategy is quite useless, because there seems to be no accountability. There seems to be no pressure on anybody to do what you hope that they will achieve, and that's the worry that I would have, and it is a big worry. You're counting on a buy-in from the PCNs, from the practices, and I'm not sure they're all going to buy into it for their own very individual reasons. And that is a great worry, because you could be wasting your time and lots of other people's time if there is no pressure. Sorry, I'm new to this. I'm very new. I've only just taken over as vice chair of the Addenham PPG, but so I'm just trying to get my head around stuff. So you'll excuse me if that was a bit of a witter, but perhaps somebody could come back on that. Thank you.
Thanks, Brian, and welcome. Philippa?
Yeah, thanks, Brian. I think, we recognise that there's some big system challenges here, but I think one of the sort of direction directions of travel across health and care is recognizing that, you know, no one part of the system is an island. And whilst we're not in the business of necessarily mandating things with GPs, as Louise says, we want to work with them. And I think we do have a burning platform, because all GPs are telling us that, you know, the demand at the moment is not manageable for them. They are struggling with recruitment, and we need to look at new ways of working together and supporting them. So I think my point was less about, well, you know, leaving the GPs to do their own thing, and more about the need to work with them and to come up with system solutions that bring the different parts of the system together to try and support each other through what is a really, really challenging time. Having said that, there are elements of the system that we can't change. We can't change everything from the perspective of Bob ICB, and we'll be working within those national frameworks and legislative and other constraints that we have to achieve that outcome. But yes, we will need to bring the GPs with us and other partners in the system. We'll all need to work together and pull together and make sure this is a compelling strategy. And one of the things that will help actually is having the feedback from sessions like this, and to know that there's support from the public as well for these changes and for the direction of travel. So that's why these sessions are so helpful actually.
Thank you. Can I just check on the feedback? Sorry, Mike, just 2 minutes. Can I just check on the feedback from these sessions? Is someone sort of taking notes? Alice, is that, you know, will this feedback be used? Okay, thank you.
That's me.
Mike, before we go to you to finish off, I think Heather had something in the chat. Did you want to elaborate on that, Heather?
Yes, it worries me quite a lot that you've said that in Bucks it's not outstanding, but we can get appointments. And I don't know where this information is coming from, because I speak to many people all over Bucks and it's appalling. In fact, in other areas, it's much easier to get appointments. So if it's down to the form that the practice manager fills in, from experience at work, any manager is, unless there's something, they want to show you how good they are. How do we know the information they're giving is true? And would it be possible to actually talk to some of the patients or give PPGs a form that we could send out to them so they could tell you their views of their surgery, and you could compare the notes then? You know, if there's no backup to anything, it's like sending salesmen out on the road. You know, if they've been a good salesman because they bring in the orders. How do we know our practices in Bucks are so good?
I think some PPGs do surveys to patient surveys. I think, Mike, you do one, don't you, at John Hampden? So it's, I mean, that is something you can do as a PPG as well. But I didn't want to answer. Does anyone from the ICB want to come?
We could do our own form then. We wouldn't need an official form.
Yeah, absolutely, and feed that back. I'm just mindful of time. I think Mike, I know Mike had a question, and then we'll go to Frank, and then we're going to have to finish there. If anybody has any other questions, if you put them in the chat, we will make sure that they are picked up and responded to. Mike, did you have a question? No. You? Yes. No, I thought you did. Okay. Frank?
Yeah, well, following on Heather's point, really, I mean, I know what Louise, I believe what Louise was saying was based on CQC ratings, we've got superb quality. And I think let's accept that and say that's reflected also in friends and family. But that is the problem, that friends and family is effectively saying, what was it like when you got to see the clinician? And for most of us, 88% or whatever it is, we've said wonderful. The issue is you can't get to see the clinician. It's all about access. And that is where I don't think Louise was claiming that we're leading edge on that at all. that is the major problem for everybody across England, well, across the UK, I suppose. It's access and continuity of care. And those are the two things that Claire Fuller highlighted in the Fuller Stocktake report, upon which this strategy is based. And it's not easy to get this right. There isn't an issue with the care that you get. There's an issue with getting that care. That was my rant.
Thank you, Frank. It's something we hear a lot about at Healthwatch as well, is access to services. Louise, do you want to finish off on that?
Yeah, so we do. The GP patient survey is one to look at, and that's where it shows, yes, they differentiate the questions. How do you feel about your access? Is it, and you can see it tracking, coming way down from last year. But it's really interesting because I think it's about understanding the whole, because some people like to have a face-to-face appointment, whereas some people don't mind seeing someone on the phone or through a video consultation, if it means that they get seen earlier. So, you know, those results are really tricky to interpret. And I think we know people aren't happy with access. It's you know, one of the areas that we do need to support them.
Thank you. I think that brings us to the end. If anyone does have any other questions, please do, or comments, please put them in the chat, and we will make sure that they're responded to and published, both on our website and the ICB engagement portal. And Alice has put, Alice, you'll be sending us details of the public webinar. I think I got my events muddled up earlier.
Oh, sorry, the office. Yeah, okay, that's fine. Yeah, I'll be sending you the details for that to publicise. It hasn't gone out on our website just yet.
That's fine. If you send it across to us, and we will make sure that we put it in our newsletter, but also we can send it directly to everyone who attended here as well.
Will do. Thank you.
Thank you very much, Zoe.
Thanks, Barry. That brings us to a close. So just thank you everybody for coming. I hope you found it useful, and thank you very much to our panelists as well from the ICB who came along and presented and asked questions. There is still time to feed back into that strategy, so you do have another month as well. So the link to the portal is in the chat. But thank you, and we will talk to the ICB about holding more of this type of webinar if it's something that you find useful. So do let us know. Okay.
Thank you.
Thank you. Bye bye, everybody.
Everyone.
Nice to see you.
Thank you for having us.
Thank you.
Bye.
Bye bye.